voted the best city to visit as a tourist, and voted the best food in the world as a tourist. So hopefully my dream is to have this congress in Cape Town, but I don't know. That's our iconic Table Mountain. Okay. Personalized treatment of hypertension. People started thinking about this in 1978, when people thought about high renin or renin-dependent hypertension treated with beta blockers. We didn't have much in those days, and sodium-dependent hypertension with low renin constituting 30% of the population. And so they devised a scheme. Those with low plasma renin activity, V hypertension, sodium volume, treat with what they call V drugs, diuretics, spironolactone, alpha blockers or calcium channel blockers, and R drugs with higher renin levels, so high levels of renin-angiotensin system, treat with ACE inhibitors, ALBs, or beta blockers that tend to block renin and deactivate the renin-angiotensin system. This really never gained much traction, except in one guideline that did try to differentiate treatment in adults to, if you're less than 55 ACE and ALB, and you're not Black African or African Caribbean, where you tended to have higher renins, and those over 55 and who are African, a CCB or diuretic. So they tried, that again did not really gain much traction. And those are the R drugs and those are the V drugs. And then most algorithms of hypertension focus on dual therapy, and basically we cover both aspects of this, R and V. So we ACE inhibitor with a CCB or ACE inhibitor with diuretic, so you're covering both bases. And this is a highly effective therapy. It's simple, it's effective, it's outcome based, there's reduction in adverse events, but it's not really precise for the average patient. Where the physiological is precision-based, select correct drugs for the right patient, possible long-term BP prone reduction of adverse events, that's possible, not outcome-based, and also we know hypertension is a complex disorder involving multiple pathophysiological processes. But as a nephrologist, I think you should go back to the kidney and think about this, why patients have low renin. And the kidney filters a kilogram of salt every day. So why is a little bit of salt so bad for you? Because in our initial environment, we had to survive on minimal amount of salt. So the kidney is hardwired to retain sodium. And the final regulator is by aldosterone or the epithelial sodium channel. That is a critical component where sodium may be reabsorbed. If actually, and the loop of Henle and the distal convoluted tube. And of course, you know, these can be influenced by mutations and variants. And you know about things that can cause terrible things like Bartter syndrome, where you can't reabsorb sodium in the ascending loop of Henle. But conversely, there are many genes that can influence, and this is the title of my second talk. So, but this is the critical area here that is the final regulator of sodium, which is a powerful influence of blood pressure and renin levels. And we also know that now, to this day, we know that primary aldosteronism occurs in about 20% of people. And this may well be occurring early and not recognized. And in fact, I did this study in 2001 and found that 20% of our patients in standard hypertension practice, not resistant hypertension practice, had primary aldosteronism based on renin-aldosterone ratio. And others showed that with resistant hypertension, they said 20%, and a lot of, based on research of primary aldosteronism. And we also know that for resistant hypertension, Brian Williams published this paper showing that spironolactone, compared with bisoprolol or doxazocine, was far superior in treating resistant hypertension. There's the data, there's doxazocine. Although there was some lowering, spironolactone was the most effective treatment, suggesting again, we're treating patients with subclinical primary aldosteronism, or what I call aldosterone-related hypertension. However, when we looked at our data between black and white patients, we found the plasma renin activity and aldosterone was significantly lower in people of African descent compared to people of white descent. Significant. Suggesting that we were dealing with patients with an ENaC mutation, overactivity of the ENaC. Okay? And this is the ENaC, and mutations here can lead to lack of degradation of the ENaC and great expression on the surface of the distal convoluted tubule and the collecting duct, resulting in greater absorption of sodium. And we actually looked for mutations of ENaC and found a new mutation in 5.9% of the hypertensive clinics in the urban area. And we gave them amiloride, which is a specific treatment of ENaC overactivity, a very considerable drop in blood pressure. Now, work across the pond in America looked at this as well, and they looked at children and adults. Let's look at the children, because this is a children's conference. Renin much lower, significantly lower in children of black origin, and significantly lower aldosterone, suggesting overactivity of the epithelial sodium channel. And if you gave them fludrocortisone, which stimulates ENaC, what happens? You got a rise in blood pressure, including ABPM in the African children, or the African American children. Change in body weight, suggesting they were training fluid, as you expect. A rise in BNP, and minimal changes in the aldosterone renin, suggesting that this was common too in the African American population. And when they looked in the Jackson Heart Study, which wrote an editorial recently, suppressed renin was a major determinant of blood pressure. The levels less than 5. And in this type, what I call the little phenotype, low renin, low aldosterone, 15.9% and 9.3% are typical plasma primary aldosterone phenotype. So overall, a quarter had this type of phenotype. This is overlooked in standard guidelines of treatment. And a Chinese study where they looked at young people, less than 30 years of age, who had suppressed renin, 1.72% had Little syndrome. Proven on genetic analysis, and of course this led to there were variants in the B channel and the G channel, resulting in BP variation hypertension. And so the blood pressure was normalized by the treatment with amiloride. So based on we've devised this type of approach, that you should screen patients for renin and aldosterone, and you have 3 phenotypes. The renovascular with high, a little phenotype, low, with aldosterone and renin, and primary aldosterone low, high, and treat with spironolactone and eplerenone, or rarely surgery, because the majority of patients with primary aldosterone have hyperplasia or genetic abnormalities causing primary aldosterone. A smaller percentage, about 30%, have adenomas, which are extremely difficult to find often. And we did a physiologically phenotyping study in 120 patients in Africa. We measured renin and aldosterone and randomized to usual care and individualized care. And 94 of the participants completed the study, 42 in usual care and 52 in physiological treatment. So we randomized them to physiological care based on those, or just usual clinic care. And the control was a change in 50% of physiological care, 11% of usual care, and systolic blood pressure 13.9, sorry, it's diastolic blood pressure. Sorry, systolic 13.9 versus 60.3%. So this was an effective study, obviously a very small study, extremely difficult to get funding for this type of study. And if we go back to the Williams study, they showed that the response to spironolactone was driven by high aldosterone, low renin, and high aldosterone-renin ratio. And they had very few patients who had very low aldosterone. So in the basically European population, they didn't find a lot of patients with a little phenotype, but it's probably still there. And if they looked at their responses to treatment in the patients with the resistance, you can see those patients who had a low renin had the best response to spironolactone. Those with the higher renin had the best response to beta blockers. And alpha blockers, well, they don't really fit into this pathway. So there you're seeing that if you get resistant hypertension, you shouldn't actually probably go with a guideline. You should look at the renin and aldosterone before deciding what your next therapy is. So based on this, particularly in resistant hypertension, low plasma renin, high aldosterone antagonist, adrenalectomy, little time, low, amiloride, and Renovactor is focused on RAS inhibition, alpha beta blockers, perhaps looking at kidney disease or renal artery stenosis. So how is this relevant to children and adolescents? Because clearly I think this is present in children. We know it's there, it's present. So should we be forming plasma renin in children and defining this entity earlier? Because it's there in 25%. And if it's low, consider monogenic disorders like Little, like Gordon's, okay? Or like primary, sorry. And if it's low, then perform aldosterone. If it's low, you consider amiloride. Or thiazide, if the potassium's high, that's Gordon syndrome, which is due to WNK mutations in the distal convoluted tubule. And if normal to high, you consider spironolactone. If you have a normal renin, you consider the current guideline approach to treatment. Now, why do I think, and in fact, the latest European guidelines have included aldosterone to renin ratio in their guidelines, basically in the European population. But I think it's also important in other ethnic populations where you may have more common little phenotype. So that will identify that for you as well. But there may be other sites, as I said, in the kidney. So if you get, we spoke about it, the Gordon syndrome, give a thiazide. If you have mutations here in uromodulin and ROMK, you consider maybe a loop diuretic. If it's more proximal, maybe you could consider a NEP inhibitor or SGL2. And we've discussed this in detail here about Little. So I think the kidney is often very key to hypertension, as we've heard from a previous speaker. So we should consider this aspect. But why do I think it's important to screen? Because when I see patients as an adult, these patients often have extensive target organ damage. This is missed in 30% of patients. And our clinic's been revolutionized by the use of spironolactone and amyloid code based on this. We don't have pure amyloid in South Africa, so we have to use amyloid code. And also, we know that now, aldosterone is produced in adipose tissue, stimulated by adipose tissue directly, particularly the visceral adipose tissue. And we know in children, obesity is driving hypertension, probably by other mechanisms, but this is clearly an important mechanism that drives aldosterone, arterial stiffening, renal fibrosis, cardiovascular disease, LDH in time. It also can be stimulated by immune theories. I'm going to have a talk by Professor Litwin about the inflammation in patients with hypertension. And we know aldosterone in the long term results in many things. Inflammation, endothelial function, cardiac, vascular function, hypertension, dyslipidemia, even type 2 diabetes, decreased gluconeogenesis, sodium resorption, and CKD. And there have been studies showing that aldosterone is linked to coronary calcium in the long term. And the effect is also driven by blood pressure, but about 50% directly by aldosterone. So you can see concentration, coronary artery calcium related to aldosterone. And then the other thing, if you look at from the Crick study, if you look at aldosterone and kidney outcome study, 11% significant risk in CKD progression and 8% risk of end-stage kidney disease. So it's clearly important. I suppose I'm being a bit provocative here in this approach, but I think we need to be reconsidering and identify these patients early, because they go for a long period with not properly controlled. Standard therapy does improve the blood pressure, but doesn't get it to target, and often these patients have a long history of poorly controlled hypertension, and they'll end up in adulthood often with bad target organ damage problems. So, in conclusion, I hope I'm on time. We haven't gained much attention, and has a role in severe hypertension categorized in patients with primary aldo, liver, or renal vascular phenotypes. It's very relevant in African population and perhaps the Asian population. Initial screening should be considered, and I think that should extend to pediatrics and children. The adults, the latest European guideline has recommended this now. Further research is required to refine this approach, and should this be considered in younger patients. Thank you very much for your attention.